Let's Achieve Change is a podcast by Pamela Grove, Doctor of Physical Therapy, Pain and Movement Specialist of Metanoia Education and Wellness Center. I propose to be that advocacy channel, making you aware, bringing the public more information on health and wellness topics, especially as it pertains to chronic pain and disabilities. I would like to be that voice for those silent sufferers out there who are not able to speak for themselves. If you'd like to know more about Let's Achieve Change, please visit our website at changeachieve.com or pamelagrove.com. If you'd like to be a speaker or you know someone else who wants to be a speaker, also visit the website and leave your email information and we will be in touch with you as soon as possible. Let's Achieve Change will air every 2 to 3 weeks, bringing you various topics on health and wellness and making the public more aware of issues that are not being discussed. We thank you very much for tuning in. Hello. Thank you for joining me today on Let's Achieve Change. I'm Pamela Grove, Doctor of Physical Therapy, Pain and Movement Specialist of Metanoia Education and Wellness Center. Listen, if you want to make some changes, you have tuned in to the right podcast. Now listen, don't forget to hit that notification button so that you can subscribe and you won't miss any future episodes on some changes you might want to make. Well, hello, everyone. Welcome back to Let's Achieve Change. We are in season 3, episode 8. And today I have a guest. Now, this was done. I want to just say this was done. This interview was done back in April, but I had to wait to bring this episode out due to some other episodes that was ahead of hers. But this information is so critical. You have to tune in because what we have found out is that this person is sharing information. She's a registered nurse by trade, but she also has served as an administrator and director with home health as well as working in the hospital system. So she knows a lot about the flaws in the medical system. Okay. So we're going to bring her on soon, but I just want to throw some questions out there first. I want to say to you, how often have you or someone in your family or your loved one or whatever that you know of has experienced increased financial burden or has had delayed healing of any particular area of their body or has maybe assume another medical diagnosis or other medical complications, and I hate to bring this up, but even has suffered mortality or death because of lack of information or because of not having proper coverage that you thought you had, okay? So that's what we're going to deal with today. We're trying to educate the public out there. I think the more we know about these different areas and have some, like a checklist of what to go down and know and ask, this is going to help us have less complications medically, have better health, have less financial burden. Don't we all want that, right? Don't we all want that? I know I do. I've learned so many things that I have because I did not know. The word of God says people perish because of lack of knowledge, okay? So we're going to get some knowledge today, okay? So I just want to bring Alicia on, and then after she comes on, we're going to do a little summary. I want you to take your pen and papers and write down some of these things that'll give you some ways to protect yourself from the medical system gaps. Okay, I'm going to bring on Alicia. Thank you. Well, hello there. Today we have Alicia joining us. Good morning, Alicia. So happy to have you. How are you?
I'm wonderful. Good to be here, and happy Easter to you.
Oh, yes. Thank you. Yeah, what's good, Easter? Okay, so listen. So we're going to dive in a little bit to more things about hidden harms that may have affected people. I know you served in the capacity of healthcare for years, and so you're coming as a very good resource of information. So I want you to just tell me in what capacity you serve in healthcare.
Okay, I've had a lot of different experiences in healthcare. I started out as a home health aide, actually, and moved to nursing at a hospital level.
Okay.
Eventually went to home health, which ended up being my first love.
Okay.
Did take a little hiatus for a while, worked from a doctor's office.
Okay.
And then went back to home health, and eventually, after serving patients in the field for so many years, I finally decided to come in the office to work as a clinical manager and then as a director.
But you were a nurse, as a licensed nurse for
yes, I'm a registered nurse.
Yes. Okay. Good job. Okay. So you definitely have a lot of information to give us here. Okay. So tell me basically what frustrations you experience, either from your perspective or other employees.
Girl, the list is long.
Oh, goodness. We only have 30 minutes.
And of course, they've changed over the years, right?
Okay.
As
Okay.
payers have changed over the years. So
Okay.
things that were covered when I first started home health through Medicaid or Medicare,
Right.
suddenly they stopped covering those things. So
Wow.
that was probably my first big frustration. Was I had patients that I could go out to see once a month, and they could have a home health aide in their home a couple times a week to help them basically get a bath and manage just the few things they really needed help with.
Okay.
And there was no family to provide that for them.
Okay.
Very first thing that happened to me within like 2 months of starting that job, that service was no longer paid for.
Wow.
They made us discharge every one of those patients. And what that meant for these patients is they had to go to a facility.
Wow.
They could no longer stay home in their own home because there's nobody to come in and help them. Just that little bit of help each week was enough to keep them there safe.
Now, do you know whether that's still no longer a service? That's not longer.
It is not a service that's provided now. No, it is not. I mean, we provide it under other payers.
Okay.
But that was covered at the time under Medicare. Under Medicare, I could go in one time a month, do an assessment, do blood work, things that the physician might want to see on a patient who's unable to get to the doctor easily. And they could have this other service in between my visits.
Wow. Wow. Oh, wow. I didn't know that. Okay. That's good information. Go ahead. Anything else?
Let's see. As the years went on, I probably should have started with hospital, to be honest. But there was a time when I worked in the hospital where, you know, when you go to have your blood work done, some people don't have very good veins. And you would have those little butterfly needles, you know, which a needle's a needle. None of them are good, but those are smaller, a little less painful, a little better for the patient care, in my opinion. They stopped allowing us to use those for a period of time because they were too expensive. We had to use, and this is what drove me crazy. You had to use a different needle first, 2 different times before you could have a butterfly needle. So how much is the cost of those 2 needles, not to mention the discomfort of the patient before you get this other needle that's probably going to work the first time? So I did argue with people over that one. I have to be honest, as a caregiver on the floor, because I was like, I don't like doing that to my patients.
Yeah.
They deserve to have the best care possible. And that's part of the best care is me making a decision whether or not I need that needle.
That's crazy. This is really blowing my mind. Okay. All right.
Well, that's the year they remodeled the cafeteria in that hospital. So I used to tell everybody when we went through there, that's where all our money was.
God. But it wasn't just that hospital, right? It wasn't.
I don't know if other hospitals were doing it at that time.
Wow. Okay.
That was really early on in my nursing career, and most of my nursing friends were in the same hospital.
I got you. Okay. All right. Okay. Well, let's keep moving on. Okay, go ahead.
Okay. So still talking about insurance coverage. Let's go ahead and move on to when I was in a management capacity.
Okay.
Just year after year, even today, I'm not a director at this point, but year after year, the cuts continue to come from Medicare.
Wow.
There's less and less money to pay for things. So, of course, the first big thing they try to do is look at the supplies. What can we do without? What do we, But it's to the point that they have to look at the visits. Like, how many visits can we actually provide before we lose money?
Yeah.
And it's not even my current company is a nonprofit company. So it's not even about, are we making money? It's just about, can we afford to, lose this amount of money?
Wow.
Before we can't open the doors, right?
Okay. Not to interrupt you, but I just want to make sure I get good clarification here. So we're looking at not so much has it been analyzed whether the person is getting better or need more care. It's just whether we're making enough money off that case, or how?
Well, there's a lot of research that's gone into it.
Okay.
And so they have this formula, like one of
Okay.
those little, what do you call those little tree formulas where if the answer to this is yes, then you move over here. The answer is yes, you move over
Okay.
here
Okay.
to help you decide how many visits you're going to be allowed to make for this particular patient. So it's based on their diagnosis.
Okay.
Like, have they recently had something done? It's
Okay.
based on what else they had going on before they had this recent procedure.
Okay. Okay.
And basically which insurance they have. So
Wow.
some insurances allow more than others.
And unfortunately, patients.
This is including Medicare. So this is including people being covered by the government's Medicare.
Wow. And the sad thing about that is most patients do not know what their coverage is, do they? They don't know, but they don't know how much.
And you will call there and you will be told something that is not true. And I believe the people that are answering the phone and trying to answer these questions are telling you to the best of their knowledge what you're allowed to have. But what they don't understand is on the back end of that. For instance, this is a good case that we had. The company I work for has both a service that does private duty type nursing, home health aid service.
Okay.
And they also have a visit service where it's like nursing, physical therapy, and you go in and do something and you leave. You don't stay.
Okay.
So the one service stays for a couple hours at a time.
Okay.
The other service, you just go in and you leave when you're done.
Okay. Okay.
There's several insurances where they will tell you that you are covered 100% for home health aid services to come in and give you a bath 3 to 5 times a week.
Okay.
But on my end of that, I can't bill for that. So since our company has both sides, we have a contract we can do with the other part of our business.
Okay.
So I would have to basically provide the therapy and things from my office, have a contract with a sister office who would be providing the service for the bath.
Okay.
And so I, as my office, would have to pay the sister office to do that care.
Wow.
But I still can't bill for it.
Okay. That's contradictory.
So obviously we're not going to do that very often.
Yeah, that's contradictory. Yeah.
It is. And it's, people are told and they will just tell you, they said I get this and I get that. And you have to be you have to be the bearer of bad news.
Exactly.
What really is available.
Exactly. Exactly. And you saw how that affected patients, right? Did that?
Oh, yes. Yes.
Did you see any type of decline or any people's health as a result of these cuts? Have you particularly?
I have.
Or did the employees comment about anything?
Well, the employees definitely comment because they definitely have a heart for these patients. They want to give them everything they can. They want them to be happy and healthy and improving. And of course, they're willing to teach caregivers, which is, we have to teach the caregivers to do a lot of different things because we can only make so many visits. It's always shocking to people to find out that they have to learn how to do their own IV.
Wow.
That is probably one of the biggest ones that has been a shock.
Wow. And that's still the case today, you think?
Yes, it's still the case today.
Wow.
And the family and the patients are concerned because, on TV, it seems all very technical and very hard to learn. And you really need to have that as a skill from a skilled provider. So it's actually not that difficult, but there are risks.
So let's look at that because I don't know much about that because you're definitely going into areas that I don't know much about. And I want to talk about those things because we need to educate people. So if a person does not know how to do that, you're trying to teach them how to do that. What kind of risk? I mean, what happens?
There's always a risk of infection.
Okay.
That's probably the number one risk.
Okay.
So in these cases, we would go out like once a week to provide care to the catheter site, which typically is going to be, it's not your typical IV that you put in your hand and take out every day. It's a line that's put in like a peripheral catheter line or a midline catheter. And it has to be changed sterile dressing once a week. Typically, we have to draw blood work as well to manage whatever medication you're taking. But between those visits, the family or if the patient is capable,
Okay.
we have ways to make it so that they can access and give themselves medication. But there's a certain way it has to be done. And of course, we educate on that. We watch the patient or the caregiver demonstrate how to do that.
Okay.
So that we know they understand what we're teaching.
Okay.
But I've had people, their line comes out because they pull too hard.
Wow.
They accidentally unscrew the cap on the end instead of just taking the syringe off. And then you've got an open line with nothing closed. That's huge infection risk.
So
bleeding risk.
So what happens in those cases if you can't go back in? They end up going to the hospital? Well,
if we know that something's wrong, such as the tip on the end of the catheter, we can go in and put another tip on the end of the catheter. But most of the time they do end up having to go to the hospital if they pull that line and break the stitches that hold it in place or anything like that. It has to be checked to make sure it's in the correct position. Unfortunately, we have had people who are addicted to medications that just so happen to be able to go into an IV. Those patients, if we know ahead of time and the doctor knows, they will not get an IV at home. They cannot have it at home.
Wow.
Because there's so many people that have actually been, I've had a patient that literally I caught putting it in there and I had to report it, of course. And it was a big, big mess.
Yeah. I understand that. Okay. All right. So I guess let's try to talk about basically, I hear the frustrations. I hear some of the cuts. Okay. If there are more cuts that we need to talk about, correct me because I don't want to leave out some major cuts. But, what things would you want to change if you could change things? Because I don't want to run out of time with that either. You know what I'm saying? So make sure.
I'd like to change the supplies. If I'm a nurse and I'm evaluating a person at home, taking care of a wound or anything of that nature, I'd like to be able to say, what's the best product to treat this patient? If I understand what that is and I'm educated on that. Because a lot of medical providers, they don't have wound care classes.
Okay.
They don't know what works. And I can sometimes recommend something that will work quicker and we could be done with it. I could give you an example of that. Once I was in the field and I really fought it out with one of my supervisors over one patient because I knew this patient. She wanted me to change the wound care to something more expensive, but you only went out like twice a week,
Okay.
Where I was going out daily. And I just begged her, give me 2 weeks. I said, you give me 2 weeks, that wound will be closed. And I was using cheap products.
Wow.
I went out and did that for 2 weeks. Wound was closed. Everything was fine.
Wow.
So I did win favor with that particular supervisor in the end, but I really had to fight for that patient to continue to do what I was doing all this time because it was working.
Yeah. So in other words, what I'm getting from this is that they want you to use something more expensive on the front end just to cut your business down. Is that what we're saying?
That's basically what the evidence shows when they've done all these tests and theories, and there's a lot of support from all different companies.
Okay.
They bring all this education together, and it shows in certain cases you can use a more expensive product and just don't send anybody out to the house. So you might go out once a week and look at that wound, and that's the only time that dressing is changed.
But you're seeing evidence that that's not always happening. That's what you're saying.
It's not always the best for the patient. Things fall off. You roll around in the bed, you can't get up, I
got you.
Dressings fall off. People try to put them back on when they don't know how to do it.
Yeah. So that's where we're going. That's where we're having the problem. So infection is a big thing. Infection.
Yes, that's a huge problem.
It's a huge problem because I'm quite sure a lot of people can also die from the infection as well.
Oh yeah.
Yeah. That's really critical. Yeah. Okay. All right. Any other systems? How about the VA system? Any problems with the VA system?
The VA system is wonderful in a lot of ways, but they're very slow.
Okay.
And they have a process of how you get home health orders comes down. Like, the doctor puts an order in, it has to go to this other department who has to approve it. Then it goes to another department.
Wow.
And they will give us an order. Well, then after that, we go see the patient and then we figure out what supplies we need. And we have to order these supplies.
Okay.
And you put the order in for that. And then you have to wait on delivery. Yeah, and I used to think that it depended because some patients got more than others. And I thought it must be based on like what year you signed up. But apparently it's based on if you were serving during wartime.
Wow.
So if you were active during wartime, I would get more visits to come out to take care of this person than I would someone who served for years, but there was no wartime during that.
Wow.
Yeah, I just found this out like last month. So honestly, I never had that. I did not understand that. But I have had to, there was a time, and this is pre-COVID, when you could actually go to the hospital, the VA hospital. And I would literally go over there to the doctor's office and get what I needed to take it to the other office so they could enter it. And then I would go to the pharmacist, which is who would hand out the supplies, and they would pack it up for me and I would deliver it.
Okay.
So there was a time I could do that, which is not something you want to do for everybody because I don't get paid for that, right?
Okay, right, yeah, okay, yeah.
But it's what was best for the patient.
Okay.
And I needed what I needed for the patient.
Right, right.
So I did it. But now you can't even go in the front door anymore.
Wow.
Unless you're approved to be, in the there to see a certain person and you have approval.
Wow. Goodness gracious. So, so first of all, we're dealing with the time factor. We're dealing with is the delay. And that can be, how long have you seen that be delayed?
A week or more sometimes.
Mm-hmm.
Especially, when we talk COVID, start talking post-COVID, everything is slow.
Yeah, let's not deal with COVID because we know COVID was a different situation. So,
but everything is slower now. In other words, when you're ordering supplies. And so, back in the old days, you could have a big stock room in the back at the facility with all kind of supplies and you could get what you need.
Yeah, I remember those days. Yeah, I do remember those days.
Now you have to have it delivered to the patient's home directly.
Oh, okay.
So therefore, you are dependent on whoever is delivering that and when it's going to get there.
Wow. Okay. I understand some of this now. Okay. So it's no longer a stock room. That's a big thing. That's okay. Because I do remember those days, a stock room. Okay. I do remember that. It's back in my old health days. Yeah. Yeah. Right. Wow. Okay. So we deal with time factors. Wow. I wonder how we can improve on that. I don't know. That's, I guess it's going through too many chains of commands. Maybe.
Yeah, there's too many hands in the pot. That's true.
Too many chains of commands. Yeah.
Because the nurse puts it in. Now everything is computer. The nurse puts it in the computer. It goes to the supervisor in the office. The supervisor approves it. Then it goes to the office that's going to actually order it.
Yeah.
So it's kind of like a process. And then what if it's a weekend?
Yeah.
What if it's a holiday?
Exactly.
These things fall through and we have no recourse. There's not supposed to be an area to keep.
And the patients don't know how to get in touch with anybody either, right? If they didn't know, they could, right? Could the patients?
Well, they know. We usually will tell them because sometimes if they call, they'll get it faster than I would.
That's what I would think. Yeah.
Yes. Yeah. So I do often give families phone numbers for things that they need.
Okay.
And say, hey, call and tell them your mother needs this. She doesn't have it. You got to get it here ASAP. The nurse doesn't know why she can't get it.
So what I'm getting from that, because I'm about conclusions, okay? So what I'm getting from that then is if we know already that the system is flawed, okay, as we know it is, and there is a time delay for a lot of things, then we should be starting to educate patients in their ability to know how they can get in touch with different people in their wherever their areas, right? In the chain of command for insurances.
Yes.
And particularly for VA as well, right?
Yes.
That will probably speed up the process.
Yeah. The VA actually is easier than almost any other insurance because once they figure it out, it's right,
Okay.
I had one little man and he would take me in the back room and go, look at all this shampoo. They keep sending me medicated shampoo and he didn't have any hair. He said, but they won't quit sending it, and he was the cutest thing ever. But so once they start getting it, they get plenty of it. It's just getting it started. So really, it's the private insurance companies and the worst of the worst.
Oh, wow.
Is going to be a commercial, these are people who are working. They have insurance from work that covers their supplies.
Wow.
And there are companies that will tell us, I had a lady with breast cancer. She developed a wound there where after surgery, they had to put a wound vac there.
Okay. Wow.
The insurance company told us they would not cover that. That's not paid for.
What?
She can't have a wound vac. And I'm like, she's a cancer patient. I mean,
Right.
it's not like she just went in to have some kind of elective surgery
Exactly.
that went wrong.
Yeah.
She is a cancer patient. She needs this. This is the best thing for her. This is what her doctor wants for her, and it will be turned down.
Wow. And then nothing else happens from that point on? They don't
The
appeal?
doctor can write an appeal, never works.
Wow.
In that case, in that scenario, it has never once worked for us. So basically, they end up having to have somebody that can take them to the doctor's office to have this process done and then take them back home, which of course they have copays at the doctor they have to pay.
Oh my goodness.
So every copay for the doctor's visit, you know, it adds up because you're talking about something that has to be done probably 3 times a week.
And how about those people who don't have anybody to take them to the doctor's office?
Exactly.
Yeah. Uh-huh. Yeah.
I mean, you know, there are services out there you can set people up with, but it's not an overnight service.
Yeah.
You know, you can't just call today and they're going to be there tomorrow.
Tomorrow to take them.
Yeah.
So it's just so many things falling through the cracks. So it's just, oh my goodness.
We have literally paid for an Uber to take patients home from the hospital because they couldn't get anybody to come and get them.
Oh my gosh.
I mean, we've done that before just because this poor patient, after everything they had been through, one more ambulance bill. I mean, the ambulance will take you home, but they'll charge you.
They'll charge you. Yeah, of course. Yeah. Yeah.
So,
oh gosh. Okay. Okay. All right. Let's see. Anything else specifically that you think before? I don't want to run out of time, but I don't want to cut you off either. But anything else, anything major that we're leaving out? I'm hearing the time restraints. I'm hearing the cuts. I'm hearing the lack of education on the patient's behalf. I'm hearing that. Anything else?
There's a lot of, I'm sure everybody's aware, you know, the hospitalization rates are very important.
Okay.
For all companies.
Okay.
So hospitals get paid, you know, they get dinged fees and whatnot if they send somebody home and they get sent back.
Okay.
And a lot of times you have a patient at home, they need to go back. They came home too early.
Exactly.
Hospital does not want to admit them. They will put them in the emergency room on one of those cots for days and leave them listed as observation for up to 3 to 4 days. I have seen this happen.
Oh.
One patient in the hallway because the ER was so full.
Oh my gosh.
I cannot even imagine spending that much time in the middle of a hallway trying to sleep and recover and be treated.
And that's only because they don't want to admit them because they'll be.
If they admit them, they're going to have to pay a fee, right?
Wow, that is crazy. And we know they're not getting the right type of care if they say
there's no way.
There's no way
you can get what you need like that. No,
there's no way they're doing that. And that's happening a lot, you think?
It happens a lot, yes. Even to my own family. And I mean, I've been there to try to advocate to say, hey, this is not working. We can't.
Yeah, I remember saying I think in Tyra's case too, as one time, I said, is she under observation? Because I use that word because if they're under observation, the insurance don't pay for that either. I've heard.
Right. That's the big catch. And so like my father-in-law, he left AMA.
Yeah.
Because he said, if I stay another day, how much more is that going to cost me when now he did not find out until the second day that he was under observation. And he was going to have to pay. And he said, well, I'm not staying a minute longer. We're leaving.
Yeah.
And that's not a good option either.
Yeah, because in the AMA, against medical. Okay, let's make sure audience understand that.
Yes, I do need to explain what that is.
AMA means against medical advice. So then that's another thing too. The insurance want to ding you on because they figure if you leave against medical advice, then they're not going to pay for that either, right? Right. Huh. So how do we get around that? Because now we got someone who's going to be dinged if they stay there for observation, but if they leave, they're going to also be dinged. So how do we get around that?
That is going to have to be something managed by politics, unfortunately.
Yeah,
I mean, there needs to be some more control over
the
way that's handled. I mean, one thing that would be great is if we all got paid the same way. In other words, if like we have this thing called a face-to-face where the patient has to go see the doctor within so many days or else I cannot bill for this patient.
Yeah.
But the doctor can get paid whether or not he sees the patient.
Okay.
So if he had to have the face-to-face to get paid, then there would be, we would be working together as a community. He would make sure he got that visit in so that we could get that visit and get paid and we would all get paid.
Yeah. Yeah.
That's one thing. There's little things like that. They're just little check boxes that the government has, and it's all to prevent fraud. I understand this,
Right.
but it's hurting people.
Right. Right. Because I think it's just not enough people just checking well enough. You know what I'm saying? I think it's
Right.
good intention, but if you don't have people who are diligent in checking what is being done and not being done, then
Right.
it falls through the cracks for people. Yeah. Yeah. Okay. Um, anything other resources, because we're gonna run out of time. Any other resources you think that would be benefit people to navigate the healthcare system? Any that you know of a little bit better? Other than
Well, about the only thing I know of that's really new is they do have navigators, a position called a navigator at the hospital. So if you're in a hospital, you can get talk to a nurse navigator.
nurse navigator. Okay.
Yeah, they
That's important.
usually use that for patients that have surgeries and procedures that are going to be ongoing
Okay.
to help them know where to go and
Okay.
when.
So,
That and a social worker, they have social workers, and anybody can get a social worker visit.
okay. So basically, people should know now to ask for a nurse navigator.
Yes, or I should have said discharge planner instead of social worker.
Okay. So nurse navigator and a discharge planner if they're in the hospital.
Yes.
Okay. They should be asking for that as soon as possible. Okay.
Yes.
Okay, that's good information. Well, you've been helpful.
I hope so. I'd
You
like
really
to
have been
be.
helpful. You really have been helpful, Alicia. Thank you so much. I just don't know what else to say at this point because it's just so much information and so overwhelming. But I think we got enough to at least give people some more information that would be helpful. God bless you.
Well, I hope so.
Yeah.
My patients have always been a blessing to me, more than I could ever be a blessing to them. And I'm thankful to God for that.
Yeah.
And I would love to see some changes come along that would be really helpful for people.
Thank you so much. Okay.
Thank
Talk
you.
to you soon. Okay.
All
Bye-bye
right.
now.
Bye.
Bye-bye. Bye-bye. Okay, so thank you so much, Alicia, for joining us today. Oh my God, what a wealth of knowledge she provided, right? She was funny too, wasn't she? Yes. So I'm going to just go down some of the main points to try to tie some of these things together. We can't do all of them, but just some of the main ones. First of all, Alicia did mention about what? When you're in the hospital, someone's in the hospital, get a nurse navigator or a discharge planner right away. Find it out right away, okay? So we can get down to knowing what you need to have for a better discharge. Okay. Another two is what the term observation. Learn that term. If you're ever in a hospital or someone's in a hospital, find out quickly whether you have been admitted or you are in observation. That makes a big difference in what you're going to be charged. Okay. That's important. Okay. The third thing is know your insurance basis, know your deductibles, know your copay, your out-of-pocket maximum. Know these things. Know what your insurance covers and does not cover. Because most of the time we don't think about that until something happens to us, right? Be prepared when you do go to your appointments, to your doctors, and when you have to do your visits. Try to get more information. Keep a list of your medications. If you don't have the ability to do that, have somebody to help you with that, okay? Track your symptoms. This helps you be able to get your doctor to a diagnosis. I think we give the doctors too much leeway to assume they know these things, but I've learned, even with dealing with my daughter's health problems, that you must be better at tracking things yourself, okay? Another thing is use another alternative to your emergency room visits. Emergency room visit chumps up a whole lot of different charges. Do things like urgent care or telehealth visits. These things are going to be less costly for you. The other thing is check into community resources. Sometimes knowing these different things for like transportation, other options out there, so you're not paying out of your pocket. Then I think the last point I want to say too is strengthen your own health. So let's get better at just making sure that we are eating better, that we are doing stress relief tactics, that we are trying to maybe go to health workshops and or involved in support groups that are going to give us information. The whole point is that we got to also do things to take better care of ourselves so that, some of the medical gaps we cannot change. Okay. So I thank you so much. I hope this has been helpful. I know I've learned a lot today. I think this gives you a little bit better understanding of what you can do, give you more power. I want you to have more power. And always remember, you have the right you have patient rights. You have the right to ask for your records. You have the right to get a second opinion. These things you have the right to do. Okay. So until next time, we'll talk to you soon. Bye-bye. Thank you for tuning in today at Let's Achieve Change. Don't forget to like, share, and subscribe. You will find out more about Metanoia Education and Wellness Center on our website at changeachieve.com. We welcome your questions and your feedback. Please feel free to fill out the form on the website and we will contact you directly. I pray that you prosper and be in good health, even as your soul prospers. Remember, it's all about the change. Thank you.